Perfect.
Okay. Are you happy to launch? We happy to launch?
Yep.
So good afternoon and welcome everybody to this symposium, and we're really excited to welcome our colleagues from the School of Population and Global Health next door. So this afternoon we have a symposium on implementation science and reflecting on how it might inform us in the work that we're doing here at NCAS, the National Centre for Antimicrobial Stewardship, in AMS across different sectors. So today's symposium was a happy result of an accidental meeting that Brian, Professor Brian Oldenburg and I had on a trip to India, where I understand he does a lot of work, and became aware of the tremendous amount of work that's going on next door in implementation science and realised that we could learn a lot. So today we're very pleased to have Professor Brian Oldenburg with us. He's a Professor of Public Health at the University of Melbourne and importantly the Director of the WHO Global Collaborating Centre on Implementation Research for Non-Communicable Diseases. And he, looking at his bio here, I think it's worth also mentioning that he's the Director of the Centre for Research Excellence in Interactive Digital Technology to transform Australia's chronic disease outcomes as well. So today's seminar, Professor Oldenburg is going to introduce implementation science, the methods and principles initially, and then our timetable has the researchers from NCAS presenting some of the challenges that they've encountered in antimicrobial stewardship, specifically in the human and animal health sectors, and we might have some interactive discussion around how we might apply the methods of implementation science to inform the work that the NCAS team are doing. So I might welcome Professor Brian Oldenburg. We're very excited to hear what you've got to teach us, Brian.
Oh, thank you. That's nice. This session's being recorded, so Arjun, you want me to stand here? I would prefer to walk around, but
you're welcome to walk around in that area.
See how I go. The other thing is, we are not in Sri Lanka, unfortunately. But I was there last week, and I did give a workshop on implementation science there for 2 days, and this lecture, this presentation. For the next hour or so, I've sort of adapted bits and pieces from that, so that's why it still has Sri Lanka on it. The other thing I should say is I'm no expert on AMR, so I'm not going to talk about that. You're going to talk about that. My expertise more relates to chronic conditions, although obviously there's important issues of overlap there with AMR. So I'll kind of talk about implementation science and probably give more examples related to healthcare delivery kinds of issues and or sort of chronic, long-term sort of chronic disease management of chronic conditions and so on. And then once some of you talk about your projects, then we can look at the cross-learnings and so on. But before we get going though, what I'd like you to do is just spend 1 minute writing down 2 or 3 things that you'd like to know about by the end of today. So I think, is this session scheduled to go to about 4? Yeah, okay. So in the next 3 hours, what would you like to know about by the end? And then if I haven't already planned to cover those points in my presentation, we'll make sure that in the discussion and your case studies we pick up on those things. And then Melissa, can I ask you to just come out here and maybe just write those points down on the whiteboard? So I don't move away from the microphone. I can throw this.
That one's already open.
Oh, okay. So I like to do this at the beginning of any sort of session like this, particularly when it's a workshop format or interaction with case studies, because I think it's good to have the list there to see how we go, how we track through the rest of the session. So people just like to say, I won't go around and do all the introductions and so on, because I think we'll use too much time, but I think that'll come out perhaps as we have discussion, people can introduce themselves. So would someone like just to say, what are the 2 or 3 things you'd really like to get out of today?
I have implementing in all the resource settings.
Okay, yep, good. And if implementation science, IS in resource poor settings.
Mm-hmm.
Yeah.
How do you choose the right framework?
Okay. How to choose the right framework, theory, model. Yeah.
Or how do you know you've got the right framework?
And how do you know when you've got it?
Yeah.
And how do you know it worked?
I guess mine's a bit of a variation of Ruby's. It's about the evidence base, particularly for general practice in our area.
I reckon if you just put up some keywords, Alyssa, just theories, models, frameworks, question mark, and then implement IS for general practice. Yep.
Just focusing on sustainability, there is more sustainability.
Yep.
Common pitfalls of implementation.
Yep. Pitfalls for implementation.
How to ensure you've been comprehensive in accounting for new stakeholders.
I'll further that one and just saying, how do you deal with competing agendas?
Okay, so stakeholder engagement and competing agendas.
Acceptability.
You mean acceptability of implementation?
Yeah.
Oh, okay. Yep.
I guess it comes a bit under engagement.
Yep. So acceptability. Any big gaps there?
Evaluation.
Evaluation. Yeah. Okay. Any others? Okay. Well, we can.
Just some of the reading I've been doing has been talking about sustainability and looking at it 6 months after you implement it. But in all of these scenarios, it's a grant and you kind of implement and then you finish. So how are there ways that you can assess that when you're not really in the picture at the time? Yeah, all the time or you're not.
Yeah. Okay. So are you talking about evaluation, or are you talking about how to move from pilot implementation to the next phase?
I think sustainability is measuring it at a longer trajectory than what you probably do at the moment, but how do you do that with your time?
I was in Sri Lanka last week, as I've already mentioned, and interacting a lot with folks from the health ministry and WHO there, and they were talking a lot about just the way in which programs are usually funded, particularly in sort of more resource-constrained settings, as pilot studies or demonstration projects. And I quite like to talk about pilotitis, like we love running pilots, but it's so difficult to get from a pilot or a demonstration project to the next stage of wider implementation and scale up. Okay, so I think that gives us one quick reflection on that list. It's a bit of a mishmash between implementation research and implementation science, and I suppose that's going to be a point that I'll come back to. I think you've done your job for now, Alyssa. Thank you. I'll get you back later. Thank you. We'll come back to many times during the afternoon about, I see implementation, research, implementation, science and implementation as being embedded with one another, and that's perhaps a bit different from the traditional way that we've thought about research and conducting clinical trials and efficacy trials and so on, which are very often run in a more ideal way, in an ideal setting, and then there's the challenges of transferring those lessons into routine care delivery and so on. So I see real-world implementation sciences as being very much interconnected with one another. The other point I'd make is I see this presentation and this afternoon to some degree as being sort of a taster session and a pilot, and I think in planning for this we sort of saw this as an idea to run for half a day and see how it goes. So it'd be good to get people's feedback at the end of this day, and you can either give that feedback publicly, or if you'd rather give it more confidentially, that's fine by me as well. Because usually I run a workshop like this with some other folks. Usually it's at least a day, and most typically is 2 days. And also I run a research training school in implementation science with the Global Alliance for Chronic Disease, and that typically goes for 5 days. So what we can do in a few hours obviously is pretty limited. But then I guess all of you are in this program, and you're thinking about implementation a lot anyhow. So I think probably a lot of what I'm saying will be familiar to you, although maybe I'll be using some language which is less familiar to you. So when I talk about global health challenges as being wicked problems, and surely AMR is a wicked problem, what do I mean by a wicked problem? What are the features of wicked problems? No easy answers. That's right. If there are easy answers, we'd already have the solutions. Yeah. And why are there no easy answers? Yeah, multiple solutions at multiple levels. Yeah. Multiple barriers at multiple levels. Yeah. Yeah. So the determinants and the influences on the problem are multiple at multiple levels, and this is just a very commonly used framework for sort of understanding or thinking about chronic diseases, and what Professor Michael Marmot often he talks about the sort of intermediate risk factors for chronic diseases, or the risk factors as being the causes of chronic diseases, and then the more upstream sort of influences and determinants such as the socio-economic context and the cultural and political environmental determinants. He often describes those as the causes of the causes. So that means, yeah, there's no single solution, and that's a very important starting point to think about implementation, because your analysis of the barriers and the facilitators and what you can do about that for AMR or any other sort of issue is going to be quite a complex mapping, and then what you're going to be able to do about it is going to involve one or more sort of different kinds of interventions and sets of strategies at one or more of the sort of entry points, but yeah, difficult to influence and difficult to influence quickly. And, I think it's a characteristic of sort of wicked health problems, global health challenges, that there's also social norms to influence, and I think that's particularly the case in sort of health systems and healthcare delivery, that there's very long-standing kind of norms and structures and systems which are just very difficult to influence and to change. I just thought I'd say a word about our unit here, our non-communicable disease unit, and the sort of work that we do related to chronic conditions, which I've got a pointer that I might just... I can, oh, okay, actually I'll just use the mouse. Okay,
So you
yeah,
should be
yeah,
able to
okay.
show.
Yeah, okay, thanks. Yeah, we look at sort of some of those determinants and complex pathways for chronic conditions. I just showed that figure for. Most interested in doing a lot of probably what you do similarly, which is implementing and evaluating novel kinds of intervention strategies, both within healthcare delivery systems, more community-wide or health policy kinds of interventions. And then, yeah, it was just mentioned in the intro, yeah, we've got one of the recently announced NH and MRC Centres of Research Excellence in Digital Health and Chronic Conditions, which I see as very much real-world implementation of new technologies and digital interventions to influence health outcomes. And then, yeah, very interested in implementation science as new methods and approaches for evaluating the implementation of those novel strategies, improving their uptake, and trying to maximise the likelihood of wider implementation and scalability. And then, yeah, we're also very involved in training and capacity building, particularly through our WHO Collaborating Centre. Got sort of work going on both in Australia, but also quite a few trials and training and other kinds of activities in other countries as well. The Collaborating Centre particularly focuses on training and capacity building, and if that's of interest to folks, happy to come back to that later on. Did everyone have a chance to at least spend 12 or 14 hours reading this monograph? 30 minutes, okay. Okay, so just this monograph, I think, is quite a nice overview of the field, albeit again applied particularly to NCDs. We do a lot of work with the Global Alliance for Chronic Disease, which is an international network of research funding agencies, including our NH and MRC, which is very much focused on an agenda of evidence development and implementation research to improve chronic disease outcomes in low middle income countries is its primary focus. And I've been leading the training and capacity building program for the Global Alliance for Chronic Disease and research training for early and mid-career researchers. So in the remainder of this presentation, then I'll talk about an overview of the field, talk about how implementation research, I think, can improve health outcomes, and then later on we'll talk about AMR more broadly and your case study. So, I mean, quite simply, what I see this field focusing on is really how to bridge this evidence practice gap, and that relates to the whole agenda of evidence-based medicine, evidence-based public health that we've been talking about now for at least the last 20 years. I guess we're primarily interested in the evidence practice gap as it relates to more public health, population health interventions, because that's what we're mainly interested in resource-constrained countries. And another way, I guess, of thinking about this is that we know a lot about what to do from more controlled and research conducted under sort of ideal conditions, but much more difficult to implement in the real world. So that's my next question. Why is that the case? I mean, why is it problematic to take interventions, programs, strategies, policy initiatives which have developed and evaluated under sort of more ideal conditions and to implement in the real world? I mean, why is that gap a problem?
If you're doing a clinical trial, there's a selection bias. So finding
Yep. Okay. Sorry, what's your name? Really? So when you say selection bias, everybody knows what that is? Okay. Yeah, I'm just not certain of people's sort of level of research training and so on. And why? What other issues are important in that sort of transfer from the research setting to the real world setting?
The world's just up there, controlled. So it's controlled, but once it's in the real world, there's no control.
It's out of control.
Or you can't control it, it's out of control. Yeah, you've got more barriers as well.
Yeah, more.
Barriers.
And why is that?
Well, as we said, we've got the control there. We've removed a lot of the barriers by whatever means in
Right.
control setting, but in real life, they're still there.
Yeah. So in the setting you work in, what setting do you work in?
General practice.
Okay. Talk about barriers in less than 3 days. No. So what are some of the barriers in?
You'll be hearing that.
Okay. Okay. So I don't want to steal your thunder. Okay. So the barriers, yes, are often much more complex and difficult, and barriers at multiple levels.
Yes.
Not just at the level of the patients or the consumers, but it's the health provider and the system and the policy and the financial.
Regulations and the provision of funding is tied to certain things.
Yeah. Okay. Yeah. Are people familiar with this book? I think this is one of the best books that, and Arjun, you'll all have access to these slides, so you don't have to. And this is exactly the same set of slides that I sent you. I didn't even remove the Sri Lanka. So this is a very good book about implementation and change in healthcare settings, both models, frameworks, case study examples, and so on, and both clinical level kinds of interventions and strategies, plus more system level ones as well. So I think this is probably one of the best textbooks on that topic. So here's a proposition. If you are implementing, overseeing or funding a health policy or program, regardless of what it is, you should always have an implementation research agenda. Some people call that embedded research. Why is that important? Okay. No, it works. What does works mean?
So that implementation, so you've got to implement it and
Okay. So you're using works in two ways, both in terms of evidence for implementation and then evidence of effective outcomes following implementation. Yeah.
I guess it's just like closing the loop of like when you actually do implement something, was there any research done before that, then what's happened, and then evaluate, and kind of looking back at that implementation research and relating back to the evaluation. So it's like
Yeah, I think that's a very important point. So it's not, and that's where I think implementation science or research is kind of different to just doing a program evaluation. It's actually designing the data and information collection system and the evaluation system so it's embedded in a sort of quality improvement cycle. So then you maximise the likelihood that what you learn from that process, and later on I'll talk about how that can be kind of staged and structured, but you will maximise the likelihood that then you will improve the program in the future. Both improve the program in terms of its implementation, further implementation in this same setting or context or with the same population, or potentially learnings for wider implementation in other settings and populations, and or scale up to a much greater level and into systems and to more widely into other populations. So we often make sort of statements about implementation. So we say many interventions work in pilots or research conditions, as we were just talking about a minute ago. but implementation faults are very common in real world conditions. So unless the evaluation and unless that quality improvement cycle is operating in kind of real world, you won't know about all of those other factors. Many different types of strategies can succeed, but they are not replicable in much detail. Policymakers define strategies, but often have limited influence on how they are implemented. Strategies often achieve their objectives, but also produce many unintended and unpredictable consequences. Have any of you been involved in a project or program that had kind of, because it was evaluated, you identified unintended or unpredictable consequences that you may not otherwise have known about, that were kind of important?
The closest I've had is a program designed to look at quality and safety in hospitals. But the unintended consequence was that the more we looked, the more we found, and the less the government liked it.
Yep.
So they in the end they stopped funding.
Okay. Because it sort of raised issues that were too complicated and difficult.
Yeah.
Or issues.
We were making inroads and improving quality and safety. But as hospitals came to trust us and the GPs came to trust us, we were finding out more and more and putting in procedures and policies and things to prevent things happening. So we were very much about using this happened here, let's prevent this happening elsewhere.
Right.
But of course the government didn't find out all of these things.
And you were running that program as a sort of quality improvement model. You were trying to make improvements as you go. And so, Kishori, I'm going to put you on the spot now. Can you, because you've been involved with WHO for many years in Syria and in your home country of Nepal and so on, are there examples of public health programs or implementation you can think of where an outcome has occurred that just wasn't predicted at the outset, either a negative or positive outcome?
So there was this, again, it's a hospital-based example that I like to cite. It was looking into nosocomial infections in neonatal intensive care unit in a hospital, in a public hospital in Nepal and in Kathmandu, and we found the results were really horrendous. And so it was very difficult to even, present it to the key stakeholders because we were not allowed to do that, because it would raise a big question to all the people, because the infection rates were very high, and it's very apt to the AMR session that we have in the next half of the day. So, I mean, there was a lot of political pressure, from the minister level not to publish the findings. And similarly, there was one more incident on patient safety assessments that WHO had developed to do in all countries, 11 countries of Southeast Asia, which had to implement that. And Nepal implemented, and the findings, I mean, it's still shelved somewhere in the ministry, it's never gone out of the patient safety. So, I mean, evaluations as such brings out issues which then, it's too dangerous to share it. But it was not even discussed within key officials in the ministry to be able to take some corrective action.
Yeah. So I think that's a very nice example, and I think demonstrates the importance, particularly in sort of low middle income countries, of having a kind of a structure and a framework kind of quality improvement model that has, ideally has the buy-in involvement of all of the stakeholders and the policy makers. So then as the findings and the learnings come to light, there's a process for then sort of incorporating those into the next iteration of the program and the further development and so on, which that's one of the problems and difficulties with pilotitis and demonstration projects, that they are rarely designed that way, because they're usually funded as a 12-month initiative or for 2 years or something, and there's not necessarily any long-range planning that this will sort of feed in iteratively to some further development in the future. So those findings come out, they're buried in a grey document or report, which often doesn't see the light of day. we had an interesting example of sort of unintended consequences, which we would only have known about, we only knew about because of our evaluation framework and the close interaction with the participants in the program. And this was a large-scale, community-based peer support intervention, sort of a lifestyle intervention, which peer supporters were being trained to implement this intervention with people with high diabetes risk in communities in southern India. And it was designed, the program was designed so that every 3 months, the 2 peer leaders for each of the peer support communities, and there were 60 of these people, would every 3 months would come back in for sort of booster training, but also as part of the kind of evaluation. And they started talking about other initiatives in their community, which weren't actually part of the initial training. The training was to be done sort of in the groups with the participants of the groups, but opportunistically or spontaneously, the leaders of the groups started running other groups in their communities and started running sessions in schools and local walking groups and so on. And it was only because we sort of had an evaluation framework that sort of captured that other activity that we would have known about it. If we just evaluated what narrowly was happening in the groups, we wouldn't necessarily have known about that. So in fact, once we learned about all those other activities, what we realised was that although this had sort of been set up as a sort of a high risk kind of intervention for people identified at high risk, in fact, the model was potentially could also be utilised as a sort of a more primary prevention model to engage other people in the community. Okay. I think this is an important point. You know, how often do you read a health policy that talks about equity and health for all and blah, blah, blah? You know, does the program actually deliver that in terms of people who are more disadvantaged, poor and vulnerable? Okay. Lots of documents and reports about the importance of implementation research and why it's needed to achieve international health goals, and we've looked at that particularly in relation to SDG target 3.4, which is the one about reducing probability of dying from chronic diseases by 30% by 2030, and just how few countries are going to achieve that. And I guess with a lot of the work you're doing, you'd be looking at SDG target 3.3 and so on. So this is sort of the importance of developing a stronger evidence base for implementation research. One of the main characteristics or features of implementation research is that it's looking at these questions. I mean, how an intervention or a strategy or a program works, why it works, exactly what is being implemented, and did you implement what you said or planning to implement, and do you have evidence with your implementation measures for that, and then also what the outcomes or the effects have been, and sort of linking the how, why and what with the outcomes and the effects. And just to be clear, when I talk about interventions, I'm using that in the broader sense of any initiative, which can be a program at an individual level with patients, at the level of health providers, policy programs, strategies, or health system change. Lots of different definitions. This is one that I quite like, which is one of the most popular ones by Eccles and Brian Mittman. Implementation research being the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice and to improve health services and public health. I think in the original definition it didn't have the public health, but I think we're also very interested in improving the health of populations as well. There are a number of different guides. You've seen the guide that we've developed, which focuses particularly on sort of prevention and control, improving prevention and control of NCDs. there's this earlier manual developed by David Peters from Johns Hopkins University and his colleagues, which looks which focuses a bit more on infectious diseases and more traditional public health problems. So you might want to have a look at that. And this is available as you can just get this as a download from WHO. I think one of the sort of challenges with implementation research is just all the terminology and the jargon. Talked a lot about this in Sri Lanka last week. I mean, don't get too fazed by that. I don't see, we talk about implementation science, and I think the fact that it's called a science, people can take to mean that this is something totally new. It's like, it's a new rocket science, so a whole new science. It's not. The word science, I think, is helpful because it legitimises the field of implementation research, and perhaps most importantly for our colleagues and peers who are reviewing our grant applications and so on, that it helps them to think that this is a legitimate field of scientific endeavour. But really the methods, the study designs, the measurement methods and the approaches of implementation science, actually there's nothing in there that's totally new. I kind of think of it as looking at the world through another kind of lens and then using methods, bringing methods together, integrating methods and approaches to answer questions about implementation, about context, about populations, about how to implement a program in a population that requires the program to be significantly adapted and so on. So the methods and the approaches are not in and of themselves. So even people talk about scale-up science. Okay, so I think of scale-up as part of the continuum of implementation and having a sort of a quality improvement model that helps you think about taking a program or strategy, developing it, implementing it, then trying to extend that program and its implementation to other populations and settings, how to then scale it up into policy and into routine care and practice. So I think of all of the methods of implementation science being relevant to scale-up science, but often, there's even one famous article, the title of which is, what is scale-up science? I mean, I don't actually think there's a specific and unique science to scale up. I think there's some important concepts and ideas about scalability which are important, but the actual methods and evidence-based and research, I don't think is fundamentally different. So what is very important is that implementation research, by its very nature, is very, very multidisciplinary, cross-disciplinary, interdisciplinary, so it really does involve many different disciplines and methods and approaches. And I think this is perhaps a barrier really for people engaging with implementation science and using the methods and the approaches. And, the question about theories and models, for example, that was raised when I was asking what you really want to get out of the next 3 hours, is an important example of this, because there's no single theory or model, there's no single framework, but it's probably also the case that for any sort of complex implementation issue or strategy, you're probably also going to use different models and frameworks. So you may well use a model or framework that helps you analyse the determinants, so you might use a socio-ecological model that helps you think about the different levels of determinants and influences that might be important. When you come to develop solutions, you might, if it's a health promotion intervention or a behavioural intervention, you might use intervention mapping or a model that helps you develop the intervention and the program in a highly structured and organised way that will bring in other social behavioural science theories and models. And then your evaluation model might be another model again. Now, there are some composite models, for example, like the pre-seed, pro-seed model, for example, which is sort of a planning and an implementation and evaluation model. But there'll be different models and theories which are relevant. But I'm happy to come back and talk a bit more about models and theories later on, just to make the point that all of these kinds of disciplines and fields are relevant. And what this means is that I don't claim to have expertise in all of these. Yet I've had exposure to all of these different fields, but that's been through my collaborations and people I've worked with. So, for example, very recently I've collaborated a lot with people in, information and computing sciences, and I've had to learn a bit about technologies and so on. But in our sort of digital interventions that we're developing in our programs for disease management, both programs for chronic disease self-management or programs that might be decision support for GPs and other health professionals. I mean, I don't develop the apps and the programs. I mean, I would give advice and be involved in that co-design process, but it's much more important to have the computing science experts and the consumers or the users or the future users of the program involved in that process. So that means that implementation, research and implementation by its very nature is cross-disciplinary and really need teams of people. Don't try and do it by yourself, because I think if you try and do it all by yourself, you may suffer from anxiety attacks or sleepless nights. This is just another way of kind of representing that quality improvement science. I think methods there and thinking, which is very important for implementation research. Let me stop there. I've got more to go, but let me just stop there and see if there's any questions or comments at that stage. Points of clarification, questions? Good to keep going? Okay. I think it's kind of obvious now how implementation research can be used. I think this is very important, this sort of learning organisations and embedding research into organisations. And I think general practice is a wonderful example of that, how I think it's become more, I was going to say maybe normative, but probably not normative, but much more common that general practice and PHNs and other kinds of organisations would collaborate now on undertaking evaluation and research, which can feed into future program development and so on. Historically, we've probably been much more comfortable with discovery research and proof of concept research than we have with actually demonstrating that implementation has happened well and program evaluation of outcomes. I quite like this graphic because it makes the point very well. I think it's good to think about when you're conducting implementation research and program evaluation, what you're focusing on. And with more ideally conducted sort of efficacy trials and so on, often you might have some light measurement of evaluation, but it's not so important. But as you go along this continuum, implementation becomes very important, more and more important. So once you get to a situation where you've got rollout of a whole program and there's already substantial evidence for the effectiveness of that program, then often the outcome measurement is very much light touch and maybe is more dependent on sort of indicators of success. What you're probably going to be much more concerned about with large scale sort of rollout or scale up is really measuring implementation. And is the program, the service, the policy actually been implemented with a high degree of fidelity, and what's the acceptability of that, and so on. And so often it's the case that doesn't happen, and yet people then conclude that the program, funded by the government or something, wasn't effective, but often it wasn't effective because it just wasn't implemented with any degree of fidelity. And then understanding why that was the case, or why the program wasn't acceptable. And very often the reason why a program is not acceptable is that it wasn't properly adapted to the context. It didn't take account of the barriers and obstacles in that context. It wasn't co-designed with the eventual users of the program, the GPs or the other health professionals, and it just wasn't properly adapted to that context. So actually, an implementation scientist would have been able to predict that the program wasn't going to work and that wasn't going to be, and maybe we'll hear some examples of that. Many theories and methods. If we've got time, let's come back to that. Implementation outcome variables. If you're going, if you're involved in implementation, then you need to think about more deeply as we think about outcome measurement. So in control, clinical trials and so on, we cluster randomised trials. We often devote hundreds of hours in design and thinking about the outcome measurement and doing sort of systematic reviews of the different measures. Often with implementation measurement, it's just kind of a last minute thought. It's either not properly included in the funding application, or it's just not thought through. And this is just a list of, commonly used implementation variables. So thinking in a clear way about which ones are going to be relevant to your program is important. One model that I think is really important or really useful for thinking about implementation measurement is called the RE-AIM framework, and some of you have probably heard of that, which is the model developed by Russ Glasgow and colleagues. So I think that's a good one. Okay. I think I'll jump over these. In the NCD area, I get very frustrated because WHO in particular advocates for countries, low middle income countries in particular, to use these so-called best buys for preventing and controlling NCDs. And I think you could, in your respective fields, you could identify what are considered to be the best buys there as promulgated by other organisations or agencies and WHO and so on. And the question is, in your context, what evidence is there for these best buys? I mean, what evidence is there that these best buys have and these strategies have really been implemented and properly evaluated with your population, in your context, your setting? And generally speaking, most of the evidence for most of these best buys, of course, comes from high-income settings, countries, and very often from research and evidence derived from controlled studies conducted under very ideal conditions. So as we said right at the outset of this presentation, the gap between that evidence developed from that research and the setting in which you're working can be very, very different. So have you actually undergone an adaptation process to kind of evaluate how well that program would work, and or how would you adapt that program for appropriate, potentially scalable implementation in your setting. And usually the evidence base, very often there's no evidence about sort of return on investment, which for wider implementation and for program implementers and policymakers, that often for them is their most important consideration. What evidence is there for return on investment for this strategy or program? Has it been adapted? What are the human resource and other kind of capacity implications of what you're talking about? So the program that might be a wonderful program, but very intensive in the kind of classically conducted trials. How feasible is that going to be conducted in your setting context? Who's going to deliver it? Is it really going to be scalable? What would be the costs of that? Are there existing people in the workforce who have the capacity to do that? Or in order for them to run this new program, are they going to have to stop doing a whole lot of other stuff? Is what you're proposing more important than what they're already doing, that task shifting? And I even get irritated with that terminology of task shifting or task sharing, because it kind of implies that there's always tasks that people are undertaking at the moment that are ineffectual and that they shouldn't be doing. They have capacity to just drop those tasks and do something else, which is often a very challenging argument to have with health professionals, etc. So I think particularly resource-constrained settings, LMIC, implementation research is a big challenge, because often the adaptation process is a really important one. And historically, in sort of public health and my kind of original background and training in sort of psychology, we thought that content was really important. We kind of assumed that in taking a program, a program that was well evaluated for diabetes, diabetes prevention, in the diabetes prevention study, wonderful efficacy trial conducted in Finland 20 years ago, the kind of content of that curriculum and program, that we could just adopt that curriculum elsewhere. And we know it's kind of really obvious, but the reason why we can't do that is the context. And I think the context is usually much more important than the content, because until you understand what the context is and how that affects program delivery, and you then co-design the program for delivery in that new context, you don't actually know what the content is. The functions and the kind of general strategies might be the same, but how it's actually implemented is usually going to, and that's kind of the work we do as part of our collaborating centre. So sort of coming towards the end of this, you might have seen, or hopefully you saw in our manual technical monograph, that the model I sort of subscribe to, which sort of has some, I think, sort of face validity to it, is to sort of think about the implementation process. We say 4 steps, but obviously it can be 1,000 steps, but at a kind of a helicopter level. You're making decisions about what to do in terms of a response, a strategy or program to a wicked problem or issue. And the response, as I said at the outset, might be multiple strategies, multiple levels, and a very complex intervention. Then you should be doing some adaptation for the context and its implementation, and some piloting of that. And again, that piloting process can be multiple piloting, multiple co-design strategies, and often that can go on for a number of years. Then you're looking at some implementation of what you've learned from those steps, and then ultimately, but often you're going back and forth and around in circles, you would ideally want to get to a point where you can more widely implement a program, a strategy, or set of strategies. Now, within that, that describes the the sort of implementation steps, but within that, there's these embedded research questions. So the kind of questions that you would be asking at this identification stage are, for example, how will appropriate policies and interventions be selected? So the first thing is sort of what's the menu of options or possibilities you could be choosing from? When you look at the evidence there, how are you actually going to identify, what kind of evidence are you going to use, and how are you going to evaluate that evidence? For the piloting, the questions are going to be how will a policy or intervention be refined and translated? How acceptable might this new program or strategy be in this new environment or context, or with this new group of GPs, etc. For implementation, that's where a model like the REAIM model could be useful, because you could be looking at effectiveness, the reach of the program, the adoption of the program, the implementation of the program, the maintenance or the sustainability. That's the REAIM acronym. So you could be evaluating implementation for each of those domains, and then scale up, you have a bunch of other questions there. So I find this model is quite good to use, particularly with kind of program implementers and clinicians, because I find that most people sort of understand the implementation steps, whether they kind of use them systematically or not, but then embedding into those steps the questions and a sort of quality improvement model, I think kind of works quite nicely. So that was why, as a sort of preparation for this session, Arjun and I sort of suggested that in thinking about projects and all the workshops we do, kind of find it quite useful for people just to fill out this 2-page, usually it consumes about 2 pages, just to really think about, what the gap is, why is this a problem, who are you wanting to intervene with to make a difference, and what might the interventions be, the stakeholder kind of engagement bit, and then what are the questions and the design and evaluation framework model you might use to answer those questions. That's my introduction. Let me finish there, and then we can move on. Thank you. So, do you want to take any questions now, or do you want to move straight on to?
We're welcome to take a few questions. After we're done with this session, we have a break of half an hour.
Okay.
There's tea and coffee outside. The toilets are on this side, for those who are unfamiliar with this building. There's a corridor to your right. But yeah, happy to take a few questions first.
Okay. Now, not knowing you in advance, I wasn't sure about the level, but now I think we can kind of tailor this more to your interests and what you want to know about.
The importance of doing a contextual analysis prior to starting the program with a local readiness assessment and understanding where you're going into is often not factored into the sort of buckets that kind of provided for these projects. And there's an example where we were asked to rewrite a training package for stewardship by the WHO, and it was a one-size-fits-all. And we immediately knew that it was not going to be possible.
Yeah.
Exactly. So we ended up convincing them that we should in-country visits to assess the state of play in hospitals across 4 countries. But I still think that message hasn't got through, given the best line country.
No, well, that's right.
Pick up something really,
exactly.
And our training fund work is the same, as you know, where we actually have to understand what the situation is.
Yeah, exactly. I think that the phrase one size fits all is perfect to characterise this, because that's essentially what the best buys are. It's a one size fits all, which is fine if you recognise these are kind of generic suggestions, albeit evidence-based somewhere. But yes, if you don't recognise then that a logical next step is that contextualisation process, and that's, I mean, how long does that take you with?
So that's a big piece.
Yeah.
But and the other thing is your comment at the very start, which is what are we actually able to modify? Because if we can't go in and modify cultural, economic, socioeconomic, these are big issues. Water sanitation, but as an implementation group, we can't modify. And we'd be very realistic in our design outcomes.
That's exactly right. So doing that sort of analysis of determinants and the levels at which those determinants are important, and you know what you're going to be able to influence. I was just going to go back to the you know what you're really going, that implementation gap. You know, what are the influences and determinants of that implementation gap, and what do you need to be able to change and influence to narrow that gap? And that's often a pretty confronting question in sort of health systems and so on, because you often realise it's pretty challenging.
Sometimes we realise we actually have to try and get the decision makers to change the structures and that existing healthcare structures to be able to do something. And then that takes influence.
Yes. And I think this is related to another issue, which is that historically doing that sort of contextual analysis and adaptation, that's been seen as a sort of an exercise you can almost just do theoretically in your head or something, you know. So that's one paragraph of your grant application, and you sort of almost feel compelled in your grant application to say that you've already done that, because if you say that the first year of the funding is to be spent on getting to the starting line, because in a sense the contextual analysis is getting to the point where you can really start to adapt the program. So it's realising that implementation science is a serious and important field, which historically, if you went to research, went to NHMRC or other funding agencies, they would say, well, this is something that the health system should just be doing. You know, it's just evaluation. But then you go to the health system and say, well, actually, to do this program in improving the communication or management of a patient clinical population between the hospital and GPs or something, it's going to take 12 months to kind of plan and to do that. The health services will say, well, that's research, you should get funding from NHMRC. So I think this kind of work has sort of fallen through the cracks.
It's more irritating to see one NHMRC health services research and being told it should be done as a randomised trial. So I think the awareness is
Can I just also add that I think in academia as well, there's that bias as well. Because as part of my PhD, which I'll talk about a bit later, I did implement something and wrote up the project and whatnot in a way that was actually an implementation science way to do it. And I was told by my panel, amongst other people, saying, well, that's not going to get you a PhD. You need to have, methods, aims, objectives, and your outcome at the end has to be like one key outcome measure. Which, throughout the process, the actual process of doing it and implementing it was actually where all the lessons to me actually were. But again, if it was the background from the academia side of it, that's not going to get
still
you
not
a
enough
PhD.
awareness. Even getting reviewers for papers.
Yeah, well, in fact, we often are critical of the health system and that it can be difficult to get support to do this kind of detailed contextual analysis work and then do the sort of complex trials and so on. But often it's our peers actually who are critical of this work. Now, I think that's changing, and I think that's, with the advent of the Global Alliance for Chronic Disease. So NHMRC has been one of the foundation partners of GACD, and Kelso, CEO of NHMRC, is actually the current chair of the board of Global Alliance for Chronic Disease. So I think it's gradually changing, and later on, if there's time, or maybe it's a follow-up session or something, but there are now will recognise sort of study designs and approaches that one can use to undertake kind of real-world implementation trials, and hybrid designs which incorporate measurement of both the implementation outcomes as well as the kind of effectiveness outcomes and so on. So I think all of these developments and language to describe these hybrid trials and mixed methods and so on, I think kind of, you know, so much in research is about jargon and how the jargon is used. I think is creating more legitimacy for this kind of research as well.
It's interesting, Brian, just reflecting on, you're talking a lot about chronic disease, and I'm sitting here thinking, how do we talk about what we do in that language? And I almost came up with the word cumulative disease, because it's cumulative in a population of so many people have infections.
Yes, yes.
We're all getting respiratory infections, and it's cumulative in a lifetime. As an individual, I'm getting infections every year. So it's this cumulative exposure to an event, an acute infection of some sort, and receipt of antibiotics. That sort of mirrors what you're talking about, which is you talk about, you use the word chronic, but there's a lot of parallels. It's just that ours aren't chronic, they're recurrent.
No, but
except some that the behaviours are kind of chronic, aren't they? The cultural behaviours. It's the same paradigm.
And similarly,
That's cumulative. It's recurrent. You're not doing it every day, but you're doing it once a year.
But I thought Brian's first slide was applicable. Your very first slide of the chronic disease thing, that fits with us as well, because it's your social context.
I thought that very first slide. Underlying social, cultural, political, environmental terms, that fits.
so I think you could map into that sort of structure
easily.
And that's a WHO slide. But I think, I think in a way, and the kind of thinking about wicked problems. I mean, it's a wicked problem. Yeah. All the multi-level influences and the societal changes and food systems and agricultural and veterinary practices and so on. That's a wicked problem. So to that extent, the same. And you know, even a lot of infectious diseases, probably think about those as chronic conditions. I mean, HIV/AIDS being managed as a chronic condition, etc. So, so I think that there's probably more commonality than first appears. It's just that maybe some of the language we use from different health fields is different, and that often that sort of mars or prevents us seeing the commonalities.
I think that's the problem. We should be trying to create commonality.
And I think that's what's happening with implementation science. I think it's and now there's bibliographies for implementation science, you know, that list the terminology and the definition of the Dictionary of Public Health, John Last Dictionary. So I think all of these developments are good because it's really creating, defining a field, legitimising the field, and raising the status of the field. But very happy to, but we may not sort of get to it today, and maybe it's a follow-up smaller session for people interested, but I usually would do a whole session on theories and models and a whole session on sort of study designs and measures, which I've kind of touched on quickly as a sort of black box, but not in detail. But maybe it'll also come out through some of the presentations. What do we break?
Break for about 20 minutes.
20 minutes? Yeah. So come back at 2:30.